Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast, I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com or now flawlessmotion.co.uk for your shoulder brace requirements. Right, on with the podcast. Pablo, welcome to the Glenohumeral Gurus podcast. It's a great pleasure for me to have you on the show and to connect with you again and hear about the work that you have been doing. Today, we're going to talk about rotator cuff and the role of rotator cuff in frozen shoulder. But first, I wondered, could you introduce yourself to the audience? We met a few years ago now, goodness, before you had children, back in Buenos Aires when we were there for the conference, and we bonded over your love of New Zealand and the All Blacks. But can you introduce yourself to the audience? Can you share with us your physio journey?
Hey, Marcy, first of all, I'd like to say thank you for having me. That's my pleasure. I need to say that I love your podcast. I've been listening many of them. I really learn with a lot of your podcasts. So for me, being here, that's a privilege. Thank you so much. Yes, I remember when I met each other, it was in 2019 in Buenos Aires, was for the International Shoulder Congress. I remember that we didn't meet each other, but I invite you to do the barbecue in my
Yes,
home. And I
yes.
and I remember that you told me, "Hey Pablo, this is the first barbecue that I eaten in a room, with roof."
Yeah, it was, yes, because in New Zealand, everybody would barbecue outside. And there we were on the top of your apartment, eating, eating all sorts of things that I have not eaten before on a wonderful barbecue. It was amazing. I still remember to this day.
So crazy, so crazy. Was in another environment, a typical city. I really enjoy this time, and I really enjoy how was the International Congress and was amazing. After that, I remembered I really enjoy your research, and today again had the possibility to be here and talking about how is my line of research in frozen shoulder and how is my clinical
Yes.
practice with frozen shoulder. It's amazing. Thank you so much. Okay, just an introduction. I'm a physio from Buenos Aires, Argentina. So, guys, if you are listening, maybe a complicated accent, yes, English is not my first language. Spanish is my main language. I think my Spanish is terrible as well, but I think that English is better. It's better in comparison Spanish to English. So, yes, I am a physio from Buenos Aires, Argentina. I graduated, yes, 16 years ago. After my graduation, I decided to do a postgraduate system in my country that the name is residence, where I had the possibility to move outside Argentina to do a clinical observation. In my case, I went to Kentucky. You know Kentucky as well.
I know
Uh,
Kentucky.
I yeah, I had the possibility to do a clinical observation with Aaron Shasha, Dr. Kibler. It was an amazing experience, because I was a shoulder lover. But after this visit to Kentucky, my love with shoulder patients, with shoulder disorders, growing up a lot, a lot. And I remember that I moved to Argentina and I continuing working with my patients. Specifically, I work maybe with 20 patients with shoulder disorders per week, approximately. Most of them frozen shoulders. I had some athletes, I mean, like rugby players, for example. And at the same time, I'm teaching at the university, doing some research, specifically talking about the research. I finally my PhD last year after 5 years. I did my PhD in Brazil. My mentor was Paula Camargo. She's an amazing key opinion leader in Latin America and all the world. So I was very, very happy with work with Paula, especially in a population that for me is, well, I try to say when speaking about frozen shoulder, we have to say that that's the worst condition about shoulder disorders. What's the reason? Well, when you see, for example, a frozen shoulder patient, you need to know that you're going to work with this patient approximately 1 year. You're going to have a lot of problems with these patients, specifically about no shots, the range of motion. You need to know that sometimes the quality of life of this patient is really poor. So sometimes our work, like physios, is very important to help this population. I love to work with frozen shoulder patients. I need to know that sometimes the recovery way is very, very long. So we need to be patient. We need to work each other with the patient. But I'm very happy to help this population. And with my PhD, I mean, I work very hard with this population. I learn a lot. So I'm very happy, not just to finish. At the same time, I'm very happy to help a lot of patients with frozen shoulder.
Yeah, wow. And how did that come about? Why? Because the PhD was because you were working a lot with frozen shoulder. Is that how that happened? Yeah.
Yeah. Well, in my practice, I work as a clinician, and in my general practice, I work in a public hospital, but
Yes.
I work as well in a private clinic. So in my private clinic, generally, I used to work and I work as well with patients, but the style is like athletes, rugby players,
Yes.
crossfitters. But in the
Yes.
public hospital, the population is a bit different.
Yes.
Specifically, that's a people with a lot of psychosocial problems, people who suffer, a lot of problem in their life. And when
Mm,
you see frozen shoulder, and when you think frozen shoulder just like a shoulder condition, I need to say that it's much more than a shoulder
yes.
condition, because this patient has a lot of problems. And when you see how's the clinical characteristics, we need to understand the shoulder profile of the frozen shoulder patients, not specifically about the bio, we need to think in the psychosocial. So
Mm, mm,
sometimes we try to resolve this situation or make easy this situation thinking in the bio, but we
yes.
need to know that the psychosocial sometimes are predominant the problem. So specifically in my work at the hospital, you see a lot of people with many problems. And when you see frozen shoulder, this is another problem with, in combination with a lot of things. I try to say, for
Yes.
example,
Yes.
I have a lot
We
of patients, they are immigrants that, for example, I work with a lot of people from Venezuela. Yes,
and we both know
yes, please.
Fabrizio Brindisino, who I'm going to catch up with to talk specifically around his PhD work in psychosocial factors. So that will be a nice section for you. But then what do you know about psychosocial factors from your work? What do you think is important that clinicians remember?
Well, it's very, very interesting your point. I would like to say that I love the research from Fabrizio. Fabrizio is great. I really enjoy reading the research from Fabrizio, and guys,
Mhm.
that you're gonna enjoy a lot the podcast from Fabrizio.
Yes.
And specifically in my case, an inflection point about frozen shoulder was a paper that was from Louis Coleman in 2018. This paper, it was just a case series with just 5 participants, but was very interesting the result of this study, because 5 people with frozen shoulder after receipt and anesthesia blocking, yeah, they had an exaggerated increase of the range of motion, specifically in abduction and external rotation. So this was very interesting because uh, it was a case series, but interesting was a shoulder condition that the problem is the capsule. How is possible that after an anesthesia, they increase a lot the range of motion of the adduction of the and the external rotation. So
Mm.
it was very interesting in the case of theory. Unfortunately, maybe the methodology of this study did not answer a lot of questions that we had. But my
Yeah.
idea after that, and in connection with my clinical practice, was I thought it, for example, I have a lot of patients with frozen shoulders that sometimes you do the assessment of this patient, and this patient has the inclusion criteria of frozen shoulder, that is the decrease of range of motion at least 50%.
Yes.
But maybe in 1 week or 2 weeks, when you recheck this patient, the range of motion increase a lot. So I
Yes.
thought, oh, oh man, this is not the frozen shoulder. Why? Because I checked the range of motion and what's the inclusion criteria of the frozen shoulder. But now, what's the reason? Because if we are discussing and talking about the capsule is an rigid structure, we
Mm.
need maybe a lot of time to modify the capsule. So I thought in this paper, and I thought in some patients that changed the range of motion in 1 day to other. So my idea was try to understand the muscle guarding that was the
Yes.
reason of the Lewis Holman study. So
Okay.
I thought in muscle guarding, and I tried to explain how's the muscle guarding and how's the role of the rotator cuff in frozen shoulder. So my idea was to discuss, okay, what's the role? And I saw some studies, for example, I remember one study from a law that they discuss about the role of the nervous system in the muscle guarding. My idea was to think about, okay, what's the role of the rotator cuff in frozen shoulder? I did a good research, and I understand in other parts of the body, like for example, lower limbs, when you see, for example, about the length of the muscle. For
Yes.
example, for this case, the pennation angle and the muscle thickness are muscle, are muscle measures to try to check how's the length of this muscle. So I connect all this idea, and I thought, how is the muscle architecture of frozen shoulder patients? Could
Yes.
this
Okay.
population, could this population, you know, uh, has a problem about the length of the rotator cuff? We have Can we have a relationship between the rotator cuff, the length, and the muscle guarding? So we did some studies to try to understand how the role of the rotator cuff, specifically in frozen shoulder. So for that, we did a series of studies trying to understand how is the real role of that.
Can you tell some clinicians now about pennation angle and muscle thickness? And because you obviously know such a lot about this, but other clinicians may not remember how muscle pennation angle changes. Talk to us about that. Give us some
Yeah, of
basic
course.
science here.
Of course, we need to understand that the pennation angle, we need to think no in macro, we need to think in micro architecture. We need
Yes.
to think very, very small. Why? Because the pennation angle is the intersection between the central axis of the muscle and the intersection of some fascicles. Maybe you are thinking now, and what's the reason of the pennation angle or muscle thickness, that is the thickness of the muscle in this situation? Well, for example, we have studies about lower limbs, specifically in hamstring, that they study how's the pennation angle to try to understand the role of the mechanical effect, like, for example, Nordic exercise, to try
Mm.
to understand if after Nordic exercise in the hamstring, not just modify, for example, the strength, the flexibility, talking about the range of motion, yes, discussing about the pennation angle, that is the architecture of the muscle. So
Mm.
when you are thinking about what's the role of the pennation angle about the muscles, we need to think in other studies. For example, we need studies from King. She's from Canada, and she studied the pennation angle in, for example, healthy people. She studied the pennation angle in people with rotator cuff rupture, and she tried to understand how's the role of the pennation angle. However, these studies, yes, had been published in, maybe, I don't remember exactly the day, but it's probably 15 years ago.
Mm.
Um, Stephen Thomas from Kentucky as well. I mean, he's working now in Philadelphia. He has very good studies, for example, about the pennation angle in overhead athletes, specifically, for example, in throwing affects the reaction of the posterior muscle, of the posterior muscle, like for example, teres minor, infraspinatus in overhead athlete. So when we try to see how is the behavior in frozen shoulder, we don't have nothing. So we try to understand how's the penation angle in people with frozen shoulder and compare with healthy people. For that, we did a cross-sectional study when compare.
Mhm.
This study was a population of frozen shoulder, and we matched this population by sex and age in healthy
Yes,
people.
yes,
And we compare how's the penation angle and muscle thickness, and we compare in both situations, just in rest, at rest, and in contraction. Yeah.
yeah,
This study is under review. So I mean, I can't spoiler a lot, but until now, you need to know, guys, that unfortunately we don't have difference between both situations. But it's very interesting to see the discussion of this study, discussing about why. Yeah.
yes,
For
yes,
example, in my PhD, one of the examination committee was Philippe Struve. Philippe is a key opinion leader, an amazing referent, this amazing guy talking about frozen shoulder. I know
yes,
you know the book from Philippe Struve talking about frozen shoulder. And we discuss a lot. I love, my defense. I love because we discuss a lot about that. Probably is, well, we assess the penation angle by ultrasound.
yes,
When we assess by ultrasound, we assess the posterior muscles like infraspinatus, teres minor, and the supraspinatus in the up
yes,
part. But probably talking about the length and the impact of the penation angle, probably the worst muscle in these situations are not these three muscles.
yes,
Probably is the subscapularis. Yeah.
yes, because of the
But
limitation and external rotation.
exactly,
It's so,
exactly.
yeah, so difficult to assess though. Is that you couldn't do that by,
It's
yeah,
impossible to assess by ultrasound. Yeah. The
yes,
other day I saw a study for Mertens, Michel Martens, that we study the reliability of the ultrasound, but discussing about no subscapularis is about the major pectoralis.
yes,
And it's about, for example, in some people that they have a secondary frozen shoulder, for example, after a breast cancer or a shoulder surgery. That is another population very different of the population that we include in our study that was primary frozen shoulder.
yes,
So, I mean, we need a lot of things to do to try to understand about,
yeah,
okay, we we could we could understand the muscle architecture, like to think in muscle guarding, or
yes.
is another outcome, is another thing. It's interesting.
Yes, it's very interesting. And when I was reading some of the work, it made me really dig into back into that muscle architecture. What do you think? What do you think you were expecting to see? The pronation angle was going to change to be so that the muscle was shorter. That would have given us an indication that the muscle had got shorter. Is that what you were thinking?
Yeah,
Yeah.
it was my hypothesis. Was my hypothesis. So thinking in that, well, I thought in the rotator cuff short. So
Yes.
in my theory, my hypothesis, it's make bigger the pernicious angle. But it was my hypothesis. The
Yes.
results of our study, we did not have differences. So
Yes.
it's interesting to see maybe, okay, another interesting point of our study is, okay, we include frozen shoulder patients, but when you see the characteristics of our population, we include just people with frozen shoulder that more stiffness than pain. So
Yeah.
probably in people who are maybe in the first stage of the frozen shoulder, maybe the situation is different because the capsule is in one situation and the role of the rotator cuff in a man who suffers a lot of pain and high irritability, the situation maybe could be different.
Yeah. You also, the muscle thickness was also the same. You might have expected
Yes.
that the muscle thickness was less because they are not using their arm as much. You might have,
Oh, what, what's my other hypothesis? We try to use as
yes,
well. We try to use the muscle thickness as well because it was a recommendation for a key opinion ultrasound leader. That, hey
yes,
Pablo, I strongly recommend you maybe use the muscle thickness like other muscle parameter.
Yes.
When we see the results, unfortunately, no. This is
No
probably
chance.
marketing, but I like the ultrasound. I love it. I like ultrasound. We
Yes.
assess the variability in propagator was good. As you know, sometimes the ultrasound has some limitations.
Yeah, yeah. Like the
Probably,
inability
probably.
maybe to look for subscapularis, it probably needs then MRI for cross-sectional area, that kind of stuff, doesn't it? To see those changes. It's really interesting work though, isn't it?
Yeah,
It was a good hypothesis. What do you think is causing the guarding then? Because the guarding doesn't come from changes in muscle architecture. What causes muscle guarding?
yes.
Yes.
Well, that's the golden question.
Yeah.
Because, well, we know that when you are thinking about the reasons of the decrease of range of motion, we are thinking about the capsule. Yeah, we are
Yeah.
thinking about the capsule. The result of the Lewis Holmes study, we are thinking maybe in the rotator cuff or other muscles. But we are thinking maybe we don't know yet the reason of the muscle guarding. I think that is a combination of a lot of things, like for example, fear avoidance. I think
Yes.
that is a combination, like for example, previous experience of the patients. It's what's the expectation of the patient, and at the
Yes.
same time, maybe we have a problem, and they showing as well. So
Yes.
it's interesting to discuss. I mean, we don't have a clear answer about what's a muscle hardening, but I really know, that the muscle guarding exists. We can see that in the patients, specifically when you see a change in the range of motion in a short time. You
Yes.
assess the range of motion this week, and the next week, the range of motion increase a lot. This is not frozen
Yes.
shoulder. This is predominantly muscle guarding.
Yes. And do you have any tips for clinicians as to how they would know that what is it that you're doing to increase the range of movement so quickly, or are there other things you then assess their fear of your
Yeah.
avoidance, or you measure that for people? Is that what you've seen? What have you seen clinically?
Well, but for me, I think that the key message for this situation is you have to reassess the range of motions. When you are working with the patient the first month, maybe you have to reassess all weeks to try
Mm,
to see if the situation changes.
mm,
After the first month that you see that it's a frozen shoulder, in my opinion, it's not necessary reassess the range of motion weekly. Why? Because sometimes this creates anxiety to the patient. The
yes.
patient asks all time, okay, how is the range of motion? I have the same flexion, I have the same external rotation.
Yes, I'm.
Yes,
Yes.
yeah. So in this situation, I mean, it's not good. But at the first moment, when you have doubts about if this is a frozen shoulder or not,
Yeah.
reassess weekly is very important to try to see if you have a huge increase of range of motion or not.
Mm. What I think is really interesting when I talk to people across the globe around frozen shoulder is the differences in our healthcare system. So last week we spoke with Michelle Martins around with my colleague Ange Cadogan, and in New Zealand, a frozen shoulder, the physio is a first contact practitioner. We would refer for intra-articular steroid. Then I would see them back. Then I would get them started on their stretching, way they go, do you know? And then but that is not the case. Well, tell us about how you see patients in Argentina, because I think that influences how practitioners work, doesn't it? How does that
W-
work?
Well, I think that we have a huge heterogeneity, because in one side, when you work with the correct surgeon, when you are working with the correct orthopedist and you have a directly line in connection, talking and discussing about the case, the
Mm,
situation is better for the patient because talking
yes.
about the information, talking about uh, the control of the expectation of the patients. But
Mm,
unfortunately, sometimes I receive, for example, a frozen shoulder patient. This patient told me, "Hey, Pablo, I saw 5 physicians and never I hear about frozen shoulder. This is my
Yeah,
first time. So
yeah.
I try to understand the situation. Why? Because, well, Margie, I need to be honest. Sometimes at the first stage of frozen shoulder, it's not easy
No,
to do a diagnosis of frozen
it's
shoulder.
difficult, isn't
But
it?
yeah, but after that, when you see that the range of motion decrease, okay, you got it. You have
Yeah,
the diagnosis of frozen shoulder. But in my opinion, when I see, for example, research specifically outside from Argentina, and I try to do a connection between the clinical practice and the evidence, I need to know that sometimes the problem that we have with this population is we don't have the control of a lot of factors that are very important in this condition. Like, for example, well, you said about Michel Martins, the studies of him and others and other studies from other parts of the world. You see, like this problem that a general disorder, not specifically a shoulder disorder,
yes,
that's when I say in a general disorder, we have to discuss about how's the metabolic system, how is the mental health of this patient, how is the environment of this patient. So we need to check a lot of things of this patient. Uh, we need to think in a lot of things and not specifically in the shoulder. Sometimes, okay, our treatment, we're thinking we need to stretch the capsule using different activities or different interventions from exercise to manual therapy, education inside. But we need to know that sometimes the environment of this patient is not the best. So in this
yes,
case, we need to discuss with other professionals. We need to support this patient using other professionals, and we need to understand. I mean, a few days ago was the publication where Fabri Brindisino is the main author, and we collaborated with him in this study, and it's an interesting narrative review that we said frozen shoulder is much more than the shoulder condition. And I think that this is the point for all the shoulder community.
yes. And so in Argentina, they would have access to a dietitian, to you would give them other types of exercises for their general health. What is current practice there?
Well, it's complicated because sometimes these patients, has no contact with other professionals outside surgeons
Yeah.
or orthopedists. So the first contact is with the orthopedist. And sometimes, well, the first treatment is physical therapy. But when I receive these patients, I try
Mm,
to translate in this information and, for example, with diabetes physicians, and like endocrinists, like other physicians with other information to try to understand the environment of the patient.
yeah. Yeah. It is actually the more we dig into this and the more I understand, really complex in terms of the number of people that actually need to be involved in this patient's care, isn't it? Where to now with your research in this space? What do you think?
Well, Margie, I am trying to publish. I am trying to publish the research of my PhD now. But the idea is
Yes.
continuing working with this population, specifically because, well, that's a population that I have a huge empathy. I would
Yeah.
like to try to help this population. I have a lot of frozen shoulder patients. So my idea is, after finish the research of my PhD, is continuing just with the same line of research
Mm,
because I have a lot of doubts that I would like to answer. But on the other hand, I'm continuing working in new line of research, working with other people from outside Argentina. I have a huge, relationship with my teammates from Brazil.
mm-hmm.
So we continuing working at the same time, and always with the gates opens to get new research to work in other population, always related with shoulder that is our patient.
Yes, yes. And you've done a number of other studies, haven't you? Looking at some, I've read some studies around scapula that you've done in Argentina. Also, you've translated outcome measures I've seen through your work. Tell us about your other work.
Well, talking about, for example, outcome measures.
Yes.
Maybe 8 years ago, our idea was, okay, we need to do science, we need to do research, but the first step to do research is we need to have some tools with a good validation for our country, because as you know, our Spanish is very different maybe for the Spanish in Spain and in other countries in
Yes,
Latin America. So
yes,
our first step, we did some translation. We did some translation, and we did some validation, like for example the SPADI questionnaire, the
yes,
ACEs as well, and the another outcome measures to work with our patients. After that, that it was the past stage. Now we need to do all the research, trying to connect our clinical practice, because in our hospital when we work, we have the possibility to do research. So our idea always is help to the patients, do research, but we need to keep the quality of working
yes,
with our patient. Quality is very important. One thing that, for example, for me, I was very happy about that was when I finished my PhD, was the satisfaction that, okay, we gave we did a very good treatment for our shoulder, for our frozen shoulder patients. So this satisfaction, I think, is very important, because sometimes you see, for example, some research that's the result of this research. Maybe for example, I love to use your shoulder test, Margie, in my clinical practice. And your research was very important for me. That's a very good connection. So my think, my thoughts are at the same time the same thing. We need to do the same research that connect the clinical practice with the good evidence to help people that are our frozen shoulder in this case, and our
yes.
our patients in general practice.
Yes. And I think what's really interesting about the work that you've done is we know now that the rotator cuff muscle pennation angle and thickness, it doesn't change. We need to look somewhere else. So even finding no
Exactly.
difference is really important for us, isn't it? To think you've,
It's important to see that we, we don't know the real the
yeah.
real the real reason of the muscle guarding. We need a lot of information to try to understand the role of the rotator cuff and frozen shoulder as well.
Yes.
We had information about, okay, the pennation angle and muscle thickness of the rotator cuff in this population, how it works.
Yes. Yes, that is not the answer. So then maybe something else. Do you have now any ideas as to how you could measure muscle guarding? Is there some kind of neurological component, or you feel like it's a psychosocial component? You feel that it's about their fear of re-injury, their fear of movement. What are your
It
thoughts?
is Well, if I had to give you an answer, I think in psychosocial components. But
Yes,
I think it's really interesting the studies about the neuromodulators and the
yes,
endocrinal components of the frozen shoulder. And I think that we need to understand a lot of things about that. For example, the studies from Santiago Navarro from Spain. He has very good studies about that to try to understand the role of, for example, the endocrinal factors in the frozen shoulder. So if I have to give you an answer, I think is psychosocial. But I mean, the way of the endocrinal, another factor, is increasing day and day.
yeah. So that we just need to understand more in that space, don't we? Yeah,
Yes, absolutely. But it's
yeah,
really interesting, Margie, that when you see, for example, in Medline or wherever, you see the number of studies about frozen shoulder, the number is huge. So
yes,
we have a lot of evidence about frozen shoulder. But however, today, until now, we need to do a lot of things to try to be better our clinical practice, because
yes.
this information, the connection with the clinical practice is not good.
Sometimes I wonder whether the patient actually does have a frozen shoulder, though that's part of the problem, isn't it? Is maybe some of the quality of the studies they may actually think they have a frozen shoulder, but it may be muscle guarding. That may sometimes I think I see patients who then in New Zealand we're getting lots of MRI now that would suggest that you have frozen shoulder based on intracapsular irritation or thickness, but they're actually an unstable shoulder that's irritating the capsule. What do you think about that? Because are these patients really a frozen shoulder? The study that you mentioned, and I've spoken with Karen Jin around when they're under anesthesia, sometimes then they have more movement. These patients weren't frozen shoulder in the first place, were they?
Yeah, well, I go to like the to ask this question from the author,
Yes.
from Louis Holman, because well, it's very interesting the situation, it's very
Yeah.
interesting because it's when you see, for example, the result of this study, and when you compare the number of the racial motion, it's a huge increase.
Yes.
It's not
Yes.
just a short increase, but in my opinion, well, I would like to discuss about how were the inclusion criteria, because when I read the inclusion criteria, that's the same inclusion criteria of most of the frozen shoulder studies, most of
Yeah.
them. But I don't know. I don't know if it was just one assessment or was two assessment, or they follow up this patient just, for example, 1 month. That it was the
Yeah.
same pot that I said at the beginning, because sometimes maybe you did the assessment of the frozen shoulder patient just 1 time, but the situation changed around the time, you know?
Yes.
So
Yes.
over time, the situation changed, and maybe we need to change that. Do
You
we need
need
to
to
discuss that?
reassess them to see whether they should be included or not if the situation stays the same, is your message.
Yeah, yeah, absolutely. I remember, for example, in one of the studies that we did, I remember a case that we checked the range of motion, the inclusion criteria were good, but after 1 week, the range of motions increased a lot. So
Yeah.
we need to eliminate this
Yeah.
participant,
Eliminate
because
those people.
obviously,
Yeah.
yes, yes,
Yeah.
because unfortunately, it was not a frozen shoulder.
Yes. Well, fortunately for the patient, maybe.
Yeah,
Um,
yeah. That's true.
Closing, Pablo, what's your message for clinicians working with frozen shoulder? What do you want them to know? I think it's really important, your message around making sure the patient actually has a frozen shoulder and not assuming that based on their limitation in range of movement. Is there anything else? What do you think's important clinicians know?
Well, I mean, the first message is about that we need to understand that the frozen shoulder is much more than the shoulder
Yeah.
condition. And sometimes maybe we think that we can work just of ourselves with the patient,
Yes.
but sometimes we need help in other health professionals to try to
Yeah.
understand all the conditions. This is about the general management of this
Yeah.
patient. But about specifically the physical therapy management of the patient, we need to understand that we need to be patient. We need to use, until now, the information that we have is we need to use the multimodal therapies.
Yes.
That maybe you don't like the manual therapy, I don't like the manual therapy. The other situation is different in one patient, but the manual therapy, specifically when you see the answer of the patients that they receive manual therapy, you need to know that maybe the expectation is different after manual therapy. So until now, the information that we have about the physical therapy treatment is that it's a multimodal approach using exercises, manual therapy, and especially the education. The education is very important to try to get the best information of the patient, to try to answer the question that the patient has, and obviously to try to understand that it's a long process.
Yeah.
We need to be patient to work in this long process.
Yes, it's such an interesting point, isn't it? Because I'm just been involved in a study recently in New Zealand looking at education versus pragmatic care for patients with rotator cuff related pain, and what we're learning is that the education is a very important part of that. But the patient expectation, so in this example, you mentioned don't measure the range of movement because it's not changing, but you're giving them manual therapy is actually not making any difference, but that's what the patient wants. It's a bit of a conflict, isn't it? Because our management isn't changing the range of movement, but that's the patient expectation. Do you have any thoughts on
Yeah.
guiding that and how we move that forward as as a profession?
Well, yeah, I would like to say that before that we cannot stretch the capsule with our hands,
Yes.
but we can modify the expectation of the patient with our hands. So this is this is interesting
Okay.
message
Okay, that's a
for this
really important
population.
point. Yeah.
Yes, sometimes you need to know, Margie. I hate manual therapy. I don't like to use manual therapy, but we need to recognize that sometimes it's very important, and in this case, to modify the expectation could be important.
Yeah. I think that's a really key thing for clinicians to hear, isn't it? Is maybe you're not modifying the capsule, but you are modifying their expectations. Pablo, in closing, is there anything else you'd like to add? What else do you think is important here?
Well, I mean, Uh, I would like to say thank you, Margie, first of all, because it was amazing to talk and discuss with you about, about shoulders. We love shoulders. We love patient with shoulder disease. We like to talk and discuss about
Yes.
patient that is one of our patients. I am very excited to see you again this year in Vancouver in the International Shoulder Congress. It's going to be amazing.
Yes.
I am following your publication, your research, and I would like to be back again in New Zealand maybe next year because
Yeah.
next year is the Rugby World Cup in Australia because I will go to Australia and maybe we will have a stop in New Zealand because I love New Zealand. And
Yes.
again, thank you so much. I mean, it's gonna be an amazing year. I'm very excited for the next step
Yes.
for continuing working with people who suffer shoulder disorder, shoulder problems. I love, to do this networking, working each other. You in New Zealand now, I'm in Argentina.
It's
I
wonderful,
hope
isn't it?
this podcast could, yeah, I hope this podcast could have a lot of clinicians and all the shoulder community, maybe people who wants to enter to the shoulder community. We are waiting for you guys.
Yes. Yeah, that's wonderful. And that's a wonderful closing remark. And I look forward to seeing you in Vancouver in September and hopefully in New Zealand as as you pass through. That'd be wonderful.
Oh, crossing my fingers.
Yes.
Thank
Yes.
you.
Thank you. See ya.
Cheers.
And thanks again to Flawless Motion for supporting this episode. So, if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.